So immunotherapy has now become a standard of treatment for many diseases. And I think in myeloma it's still in its infancy. But probably the therapeutic modality that's the furthest advanced right now are CAR T cells, specifically BCMA CAR T cells that have shown very high response rates in patients that are multiply refractory. I think, however, that the challenge remains that this is still very early in the clinical development of these cells, and so despite these very high response rates, what is still unclear is what the overall duration of response is going to be. However, what this has done is generated a lot of interest in further clinical development, and I think over the next 1 to 2 years we'll begin to understand a lot of this. And then there are a lot of other things that are coming up that will also prove to be very interesting and integrated very nicely into the treatment of multiple myeloma. Well, I think the MMRF is already doing a lot. Certainly, there have been significant funding opportunities that the MMRF has put forth to enable teams of researchers to study collectively specific aspects of how immunotherapy works. I think the MMRC has been critical in terms of a lot of clinical trial development that is going on. And I think this partnership with academia and industry and biotech has been critical to the velocity with which a lot of these things have progressed. There's a lot of challenges. I think, we're still in the infancy. I think there's a lot of very exciting data, but we don't know still who the ideal patients are. So patient selection is an issue. I think when one looks at the durability, for example, of CAR T cells, the question is, how can we potentially identify patients that stand the highest likelihood of benefiting, especially for therapies such as CAR T cells that has a significant toxicity associated with it, but more importantly, I think has a significant price tag associated with it. And for society to sustain those kinds of costs, I think it's really only warranted if the cost benefit is as high as we can possibly make it. And so I think where the field is moving in general is really trying to do a better job at identifying patients that a priori may be more responsive to immunotherapy, or to potentially modulate the patient's immune system to augment the overall efficacy of their therapies. So immunotherapy differs from conventional therapy in several ways. One is that for the most part it is a patient-specific therapy, as we talked about earlier. Unfortunately, it's so much more labor-intensive, many of these. There are challenges in terms of manufacturing. CAR T cell therapies can take up to 4 to 6 weeks to make, and so this isn't an off-the-shelf product that you can just get for somebody. And so by definition, you're probably losing some patients that really can't wait those 4 to 6 weeks to get the therapy. And there's manufacturing issues associated with a lot of these things. So classical chemotherapy is something that's in a container that you just pull off of the shelf and administer to the patient within a few hours of writing the prescription, which is not the case with a lot of this immunotherapy. Our project is really attempting not necessarily to develop a new therapy, but to better understand what the immune response is at various stages of disease. So for example, from the transition from smoldering to active myeloma, or patients that have high-risk myeloma, or patients that are enrolled on immunotherapeutic trials that may respond versus those that don't. And one approach that we've decided to look at is really a very in-depth characterization of what the immune infiltrate is, by going through the variety of different cell types, both at a cellular level as well as at a molecular level. And as we develop these numbers, to begin to put this data together to develop what we think would be a predictive algorithm to either characterize patients as immunoresponsive or not. We have therapies, immunotherapies, that work. And they work very well in certain people, and they don't work at all in other people. And considering the cost and the labor that's involved in this, for immunotherapy to be successful, we have to maximize its use in the patients that have the highest likelihood of benefiting. What we're trying to do in this proposal is to understand who those patients are, and hopefully, therefore, triage those patients towards immunotherapeutic type-based therapies, and in contrast, be able to go to a patient and say, because of the nature of your disease, the likelihood of you responding to a specific type of immunotherapy, or even immunotherapy in general, is much more limited, and that may not be the right option for you. And I think we already know clinically that not everybody is responding well, and so we need to try to figure that out up front. That's a very good question. Is it the cancer or is it the immune system? And the answer is it's probably both. I mean, the cancer is probably doing something to the immune system that's rendering it ineffective, and an effective immune system is then incapable of fighting the cancer. And so that's why we are not taking a biased approach, but we're looking at everything. We're looking at the tumor, we're looking at the immune environment, and we're also looking at the non-immune environment within the bone marrow to try to develop these algorithms.